Dr. Lisa Richardson is a mixed blood Anishinaabe physician and clinician educator in the University of Toronto's Temerty Faculty of Medicine. She practices general internal medicine at the University Health Network and is a strategic advisor in Indigenous health for the Faculty of Medicine and for Women's College Hospital, where she founded the Center for Wise Practices in Indigenous Health. She's an associate professor and vice chair of culture and inclusion in the Department of Medicine and also an education researcher in the Wilson Center. What don't you do? Dr. Richardson is a powerful advocate for Indigenous health equity at both the local and national level, and her contributions have been recognized through numerous local, national, and international awards. I am such a fan. We are so lucky to have you here and lucky to have your work and your leadership. Dr. Richardson, over to you.
Thank you so much, Samantha, for that lovely introduction. So I'm going to speak now in my, I'm going to put on my clinician hat and also my health equity hat. So I have had the privilege, I would say, of caring for patients who were first admitted with COVID back in March when this condition first developed. So in my practice as a general internist, we do care for patients with COVID. We have dedicated teams of patients with COVID. So I'm able to see the clinical manifestations in for people who are hospitalized, and unfortunately for those to go to the intensive care unit. But I also have been working in my work as an Indigenous health leader extensively around vaccinations, and I've vaccinated now hundreds of people. So what I'd like to talk to you about briefly today are just what I've observed around some of the questions that have come to me related to vaccines. So I'm going to work through some of those and then speak a little bit about what I've observed around equity and how that's playing out, particularly around where we need to get vaccines urgently. So commonly, who should get the vaccine? Obviously, we know everyone ultimately needs to get the vaccine. The National Advisory Committee on Immunization, NACI, as Dr. Sharma has spoken about, has articulated very clearly who priority groups are, and those phase 1 priority groups, again, were based on age and those in congregate settings, just because we know that those people would get extremely unwell and have a higher mortality from COVID. So the subsequent priority groups that you're seeing are all also very evidence-based, looking at who gets COVID and how severe COVID is, and trying to make sure that we're getting vaccine to those groups urgently. Ultimately, we will all get vaccine, including our children, once they've been studied in trials, and we're still waiting for some of that data. But I do want us to be aware that the delineation of priorities has been thoughtful and evidence-based. I'm grateful to be working actually on one of the prioritization subgroups here in Ontario. Who should not get the vaccine? We're going to talk in a little bit more detail later, I think, about some of the nuances around those who are immunosuppressed, safety in pregnancy, safety in those who are breastfeeding. So I'm not going to get into those details. There are really only two absolute contraindications, meaning two groups of people who should absolutely not get the vaccine, and those are people who've had a previous anaphylaxis reaction, meaning a severe allergic reaction to a COVID vaccine, so people who may have had their first dose and had a reaction, or people who've had an anaphylactic reaction to one of the ingredients in the vaccine. So you'll notice, for those of you who've had the vaccine, you're often put through a series of questions. Do you have an allergy to something called PEG? And that will be explained to you by the person who's vaccinating. What are the benefits of vaccination? We saw the data on that last slide by Dr. Sharma. All of the vaccines that have been approved in Canada decrease the likelihood of hospitalization to zero, as you could see from those trials, and the mortality. So we're hearing a lot of back and forth. Oh, I want to get AstraZeneca. I don't want to get the Johnson & Johnson, or I don't want to get AstraZeneca. I want to get Pfizer. I want to get Moderna based on the efficacy. What's really important to know that the endpoints that matter, hospitalization, severe disease, and ICU admission and death, are all reduced to zero by these vaccines. So please take whatever vaccine you can get as quickly as possible. What are the risks? I suspect we'll have a more fulsome conversation later about some of the new concerns about vaccine-induced thrombotic immune thrombocytopenia, which is similar to heparin-induced thrombocytopenia. Very, very, very rare complication. And as you know, we have not chosen to, we still believe in Canada, and it's still being deployed actually across the world, that the AstraZeneca vaccine benefits of taking it outweigh those very rare risks. What vaccine should I get? As I said, please take whatever one you can get as quickly as possible. How will I feel after? Most people do feel a little bit. Most of the trials show people get a sore arm. Some people get a little bit of a flu-like illness. It's more likely for the 2-dose vaccine regimens that you'll get that after the second dose. And one that's coming up often to me, do I still need to follow vaccine precaution, public health precautions after I've been vaccinated? Yes, you do. We know that based on your immune status and also age and other factors, it takes at least 2 weeks to develop full antibody response, even after dose 1, and one can still be contagious. So it's important if one has asymptomatic disease. So public health precautions are still critical in terms of social distancing and not gathering with people. Now I'm going to switch for the next just 2 minutes to talk briefly about my work around vaccine hesitancy, and this is very much aligned with, of course, health equity. We have seen with COVID that it has exposed major inequities that we have always known existed. It has brought them to the surface. We now have ample data across the globe, actually, based on how these inequities are playing out. There's a preprint that's will be published soon out of Israel, showing how people with lower socioeconomic status were actually less likely to take the disease, to take the vaccine despite access to it. I actually think that it likely has a lot to do with what I call, how do we create vaccine confidence? How do we let people know that this vaccine is safe? Particularly if you're from a structurally marginalized groups where there's been forced experimentation, forced vaccination, or other unethical research that's been practiced on you or your community, such is the case with Indigenous and Black peoples in Canada. We know that in Ontario, and actually consistent with StatsCan data across the country, those who are from lower, particular postal code areas have a much higher risk of disease. And in fact, what we saw in Ontario from the science table is that an 80-year-old in that highest risk postal code area would have a mortality rate 27 times higher than an 80-year-old in a lowest risk postal code area. And that a 50-year-old in the highest risk postal code area had a higher mortality rate than an 80-year-old in a low risk area. What does that tell us? That this is about much more than just postal codes. Likely the people living in those areas, there's a higher concentration of essential workers, a higher concentration of racialized and visible minority people. So we need to address these high risk areas. Thirdly, when we look at the data around Indigenous peoples in Canada, we are now seeing rates that are 74% higher on reserve than for other Canadians. We're also seeing in the Manitoba area, where we have robust data, that the rates of mortality and ICU stay are much higher for Indigenous peoples. So all of that to say, we need to create a vaccine strategy that actually addresses how do we target people? How do we reach people? I don't want to use the word target. How do we reach those of us within our communities who are most at risk? And some of it is related to the medical conditions and age, et cetera, but much of it is related to these other structural determinants of health. So I'm going to leave it there for now, and I look forward to further questions. Miigwech.